Hey everybody, welcome back to Pathology. Today we're going to go through the immunohemolytic anemias. Starting off with alpha thalassemia, once again, there is going to be either a carrier or a trait or disease, and it depends on how many chains have been deleted. Hydrops fetalis is going to be deletion of all 4 alpha globulin chain. It's going to be incompatible with life. How can it occur? It can occur due to the placental thickening, excess amniotic fluid, and it presents with anasarca. And there is, of course, the genetic component. Clinically, it's similar to Rh incompatibility with the anasarca and the abnormal amount of fluid in the abdominal cavity, heart, and lungs. And then there's going to be these cystic hygromas formed, like right here and right here. It's going to cause intrauterine death, and there is going to be here, as you can see here, massive hepatosplenomegaly. So in alpha thalassemia, the schistocytes are going to be present, and that's due to the microangiopathic hemolytic anemia. The teardrop red blood cells, or dacrocytes, are going to be positive. And within the red blood cells, there's going to be something called basophilic stippling, and that is a signal for bone marrow injury. So here are your schistocytes, and here, and here are your dacrocytes. Paroxysmal nocturnal urea is going to be an acquired mutation in the PIGA gene. It can be X-linked or it can be acquired. So in the genetic component, there's going to be cells that are deficient in the CD55, which is a decay accelerating factor, and CD59, which is a membrane inhibitor of the reactive lysis, and CD8. So there is going to be problems with the red blood cell stability because respiration at night decrease, so of course your pH is going to be low. Normally the complement proteins are going to be activated due to the water in the blood, but with the pH lowered, there's going to be more acid, so they're going to be inactivated. And then intravascular hemolysis is going to occur due to the inactivation of the complement proteins and the activation of the MAC lysis or the MAC complement membrane attack complex right there. There is going to be death due to thrombosis, bleeding, and infections, but it can develop into the acute myeloid leukemia or myelodysplastic syndrome. So in these patients, the hemoglobin is going to be low due to the lysis of the red blood cells. Reticulocytes are going to be increased, of course. White blood cells and platelets are going to be reduced. There's going to be hemoglobinuria or hemosideриnuria after waking up, and the bone marrow is going to be hyperplastic. So we confirm the diagnosis by a sucrose hemolysis test or a HAM test. The warm antibody type of hemolysis can be primary, which is going to be idiopathic, or secondary, and that's caused by the B-cell lymphoid neoplasm, systemic lupus erythematosus, medication, walking pneumonia, mononucleosis infection, mutation in CD40 ligand, or plasmacytoma. It's going to result in the extravascular hemolysis. So, of course, extravascular is going to involve the spleen. It's going to be characterized by IgG, and spherocytosis is going to be found in the peripheral blood smear. And their lysis is going to be caused by the microangiopathic hemolytic anemia. So in malaria, the infectious agent is the Plasmodium malaria, and it can present as either a tertian fever or a quartan fever. This is the most dangerous one. It only affects the red blood cells. Treat it with the quinines, and You have to ask if the patient has G6PD or has anemia, because these medications are contraindicated. P. falciparum is the most serious of the malarial strains because it has a similar presentation to tetanus. That's the bridge formation due to the spastic paralysis, and that's going to be because of the microthrombi. It's characterized by this rosetting formation of the red blood cells, and the the endothelial-cytoadherence is going to cause the microthrombi. Cold antibody type, on the other hand, is going to be characterized by IgM versus IgG, and it's going to be cold hemoglobinuria, where when the urine is placed in decreased temperature, there's going to be clotting formation. It's going to be due to intravascular hemolysis instead of extravascular hemolysis. And it occurs more in children, especially after a viral infection or a mycoplasma infection, mononucleosis infection, CD40 ligand mutation, or plasmacytoma. You treat the patients with the immunosuppressants and the splenectomy. Iron deficiency is going to be the most common iron nutritional deficiency, and there's 3 stages. First is going to be just the reduced ferritin levels, and then there's going to be decreased actual iron, and then there's going to be the anemia. So in the reduced ferritin, hemoglobin is actually normal. The bone marrow is going to be suppressed though, so you do want to catch it in between these stages because it's easier to treat. In this phase, or stage 2, the bone marrow is going to be depleted, and the hemoglobin in the peripheral blood is actually starting to show signs of the deficiency. In stage 3, this is going to be complete absence of the bone marrow. There's going to be a dry, as you can see, it's going to be a dry tap, and the iron stores are completely exhausted. And now you present with anemia symptoms along with ice chip chewing. This is actually one of the hallmarks of iron deficiency. The red blood cells are going to be microcytic, and they are going to be or once the staging has progressed, like there's going to be heart failure cells in the lungs. So they're going to be citroblastic. So once again, ferritin is low, transferrin is low, but the binding capacity is high. Hemoglobin is going to be initially normal, but then eventually it's going to be low. So you want to check the transferrin for the iron level, not ferritin, because ferritin is going to be an acute phase protein. It doesn't mean anything. It's non-specific. Total iron binding capacity is going to be the sum of the unbound apotransferrin and the ferritin-bound transferrin. So serum iron, on the other hand, is going to be just the iron bound to transferrin. So, as you can see here, this is important to know. So, iron deficiency, decreased iron, decreased ferritin, increased total iron capacity, increased transferrin. While in the thalassemias, minor versus major is going to be increased iron occasionally. Increased ferritin, decreased total iron binding capacities, and decreased transferrin. So basically the opposite of iron deficiency, which makes sense because the thalassemia would be an iron overload. So kind of important to distinguish. There's going to be increased platelet count, decreased hemoglobin, of course, in the later stages. The hematocrit is going to be decreased, and the red blood cells are going to be microcytic and hypochromic. So they're going to be very small and very pale. They're also going to have changes in their shape and their nuclei, because some of them could be like teardrop cells or pencil case cells, or they can be target cells. And there are going to be decreased reticulocytes. So the plummer-vinson syndrome is an important syndrome that you have to pay attention to, because it can present with a lot of like eating disorders too, because it is one, a iron deficiency anemia. Two, there's going to be esophageal webs, and that's going to cause the dysphagia. Other symptoms would be like the glossitis, angular cheilitis, koilonychia, which is like the spooning of the nail bed, and usually it affects women from like 40 to 70 years old. So we treat them by giving patients the iron, and you monitor the reticulocytes. Anemia of chronic disease is going to be associated with like chronic microbial infection, chronic immune disorders, neoplasms, and it's the most common form of anemia in the hospitalized patients. It presents with inflammation. Inflammation is going to have like all those immune cells like reacting, so those will react to the red blood cells as well. And it can also be due to antigen mimicry from other cells or transfusions. So the red blood cells are going to take the brunt of the attack. Hepcidin is going to block the transfer of iron from the macrophages to the erythroid precursor. That's why there is that anemia. So due to the higher hepcidin level, there's going to be low transferrin and low total iron binding capacity. There's high ferritin, so there's more sequestration of the iron. And if you give patients iron, especially in women, like give them too much iron, there is an increased amount of infections, or there can be chronic infections due to the iron available for the bacteria. Citroblastic anemia is a group of disorder, and it's characterized by abnormal erythropoiesis in the bone marrow. So there are going to be abnormal intramitochondrial accumulation of iron due to a defect in the heme synthesis within the mitochondria. So it's going to present with these sideroblasts. So they're going to be their heart failure cells, pink, iron accumulation inside, dimorphic red blood cells, and there's going to be hyperplastic bone marrow with these ring sideroblasts right there. And that's all due to the increased iron storage. Megalobastic anemia is due to a B9 deficiency, so you have to ask your patients if they're vegan. It can also be due to chronic oral contraceptive use, because oral contraception will prevent the absorption of the B vitamins. So you need to give the folic acid to make the thymidine for DNA, and thus if you have a B9 deficiency, you give folic acid. In pernicious anemia, the symptoms are somewhat the same, but in the pernicious anemia, there are CNS, central nervous system symptoms due to the fact that B12 is needed to make the myelin. So it's pernicious anemia because it's not just B12 deficient, it's also an intrinsic factor deficiency. So you had to give both the folic acid and B12. So the B9 deficiency, once again, there's no neurological symptoms, but B12 there is. Deficiency of vitamin B12 and 9 will cause a defect in the nuclear maturation and block in the cell division. But the cytoplastic maturation is unaffected. That's why it's now megalobastic. So the cell just gets bigger. It doesn't divide, it just gets bigger. It's a phenomenon called nuclear cytoplasmic asynchrony. So the megaloblasts will have the immature chromatin, but they're going to have plenty of material to divide. The hypersegmented neutrophil is going to be your big red flag. and you check it for your B9 or B12 deficiency. The shilling test is one of the tests that we give to see if where the B12 problem is, right? Could it be due to malabsorption? Could it be due to malnutrition or whatever? So if the radioactive B12 is in the urine, is going to be caused by the nutritional deficiency. Pernicious anemia, B12, and intrinsic factor deficiency is going to be caused by these chronic atrophic gastritis or achlorhydria. It's going to be characterized by these giant metanielocytes, megakaryocytes in the blood, macrocytes, and in general pancytopenia. First sign is going to be these hypersegmented nuclei or neutrophils of the nuclei of the neutrophils, and then eventually it'll lead to the demyelination. You're going to lose senses, sensation, and proprioception, and unfortunately, the neurological symptoms are irreversible even if we give treatment. The treatment is just to slow the progression of the disease. Type 1AB, there can be a blocking of B12 binding to intrinsic factor. Type 2 antibodies are going to block the binding of the complex to the ileal receptors. Type 3 antibodies are the antibodies that are produced against the alpha and beta subunit of the gastric proton pump. So this is going to cause the achlorhydria. So basically, there is not going to be any like hydrochloric acid to help the intrinsic factor be activated and absorbed. In these patients, they have like a yellowish skin, mild icterus, atrophy of the papillae. They also present with autoimmune gastritis and metaplasia of the gastric and esophageal junction. So you give the shilling test to see where the problem in vitamin B12 is, and there should be low cobalamin in the urine, but there that means that B12 is absorbed, right? So if it's high, that means it's not going to be absorbed. If it's increased, it would be in the form of methylmalonic acid. Okay, so in aplastic anemia, there is pancytopenia. It's a chronic suppression of the multipotent myeloid stem cells, so it's going to be a decrease in all of the myeloid lineages. The stem cells are going to be antigenically altered by drug exposure or infection, and the activated T helper cells are going to make interleukin 1, TNF, and interferon. It's characterized by the splenomegaly, and you treat by the bone marrow transplant. As you can see here, the aplastic bone marrow is going to be just filled with fat, so you do need to replenish the cell lines. How do we know it's working? To see if the reticulocytes are present. So we have to exclude the myelodysplastic syndrome because they can kind of masquerade as a megalobastic anemia. So in leukemia, there's going to be increased amount of white blood cells. Aleukemic leukemia is where the white blood cells cannot mature and leave bone marrow, but they're there. Acute leukemia is going to be an increased amount of immature white blood cell precursors in the periphery, and they all have similar features, so they're all nonspecific. Pure red cell aplasia, however, is going to be caused by parvovirus B19 or a thymoma, or large granular lymphocytic leukemia, and it's going to be marked, or it's going to be characterized by anti-erythropoietin. Polycythemia vera is going to be caused either by smoking, dehydration, or physiologically it's going to be caused by dehydration or high altitudes. where there is extramedullary hemolysis, in particular the spleen and the liver. It's going to be characterized by those dacrocytes and hyperviscous blood. The primary cause would be low erythropoietin, and there's just going to be abnormal proliferation of the myeloid stem cells. And in secondary, the polycythemia vera is going to be caused by increased erythropoietin, and that's due to the renal cell carcinoma, hepatoma, cerebellar hemangioblastoma. So that's it for now. Thank you for your attention and good luck studying.